You are listening to Inspired Caring with Michelle Magner, episode number 148. Hello, welcome to Inspired Caring. I'm your host, Michelle Magner. If you are caring for an older family member, this is the podcast for you. Each week, I bring insight, tips, inspiration, and strategies to help you care for the people that you love without losing yourself along the way. Having cared for both of my grandmothers, I've helped manage everything from hospital stays, households full of belongings, to navigating senior living and end-of-life care. And I've worked in senior living as a result of that experience, serving my residents and their families as they've been on this journey too. Thank you for joining me today, and I hope you enjoy this episode of Inspired Caring. In today's episode, we are going to hear from Dr. Monique Nugent. She is a practicing hospitalist and an associate director for the Division of Hospital Medicine at South Shore Hospital in Weymouth, Massachusetts. She is also the author of Prescription for Admission, a doctor's guide for navigating the hospital, advocating for yourself, and having a better hospitalization, a complete guide providing the critical information you need to navigate the hospital. With her advice, readers can stay calm, feel confident, and focus on healing after a crisis. Dr. Nugent and her book are an excellent resource for navigating the confusing world of hospitalization and healthcare. She is passionate about advocating for every patient by working to make healthcare equitable, safe, and high quality. I hope you enjoy this episode with Dr. Nugent. I am very, very excited to have this conversation today with Dr. Monique Nugent. She is the author of Prescription for Admission, and you heard a little bit more about her in her bio, but I feel like you have written the book that we have all been waiting for. So thank you for being here today.
Thank you so much for having me. I'm really excited for this conversation, and I'm really excited to talk to your community, because when I first wrote the book, I kind of very naively thought that this would be a book for everybody. But what I've found is that the community of caregivers really are the people who were looking for this message. And so I'm excited to be embraced by that community and be of service. So thank you for having me.
Well, we welcome you. We're happy you're here with us. One of the things, there were a few things when I was looking at the excerpt of your book and just some sample topics that were presented that I think people really are struggling with is how to advocate for someone when they are going to the hospital. And I think oftentimes in my experience, it's an emergency situation that has brought them to your door in the first place. There was a fall very often that has happened. And so families they just get a little freaked out and spun out. So let's start with just advocating for their loved one who is now your patient.
Yeah, so there are two types of hospitalizations, just like you hinted at, things that are planned, right? I've signed up to get a new knee. I have a date. I have a time. I show up. I'm excited. I've been pregnant. I'm going to have a baby. These are hospitalizations that people can prepare for. And then there's unexpected hospitalizations, right? The slip and falls, somebody who has a chronic or progressive illness now has a flare, or something that, like a common cold, has this kind of knocked somebody down, and their chronic illnesses are kind of again flaring and making the situation more complicated. And those are the times that the unexpected hospitalizations are full of what? Fear, right? They're full of worry. Now there's emergency, not just on my end as the clinician, but on your end as the caretakers and the family. How are we going to do this? Because as much as mom is in the hospital, dad is in the hospital, you also have kids and work and life that still needs to be going on. So how are we going to hobble the pieces together to get through what in the US is about 5 days? Like the average hospitalization is around 5 days, right? There are quicker hospitalizations and there are complicated, but My book, I picked 5 because that's kind of the average. So advocating for someone, I always say, starts well before a hospitalization. And it starts with preparing. If you are caring for somebody, preparing so that if something happens, you are what I call the owner of clear and consistent information,
Mm.
right? You don't have to know everything, but you should know where to get that information, because the first thing you're going to advocate for is a safe care plan. And a safe care plan hinges on information. The
Mm.
more information your care team has, the more they're able to say, this medication is safe to continue, this one isn't. Okay, they have a history of this. We need to watch out and maybe prescribe something for nausea earlier rather than later. The first thing you're going to be advocating for is a safe care plan, and safety hinges on information. So if you're able to be the owner of that information or know where to get that information, what meds does the person you're caring for take? Right? Were there any recent changes? Are they on oxygen? Are they on 2 liters of oxygen usually? And today it's 6. That's a
Mm.
big difference. Right. And so, like, you as the caretaker, you have that information. You know, mom is usually an alert oriented times 3, gets up, does her garden. This is very different that she thinks that it's 1974. Right.
Mm.
Or mom always thinks that it's 1974, but she's usually much more awake. And now she's looking drowsy. Right. I, as your hospice or any other provider, we don't know your loved one,
Mm.
right? So you're able to give us that background. And the more information the health team has, so again, being a hospital based physician, what is in that medical record for me is the information that I have. And if you've been to that hospital or health system before, you've kind of built a story, right? I have past labs. I know what was prescribed in the past. I can see your primary care doctor's office or the last discharge summary, whatever it is. But if you're brand new to a hospital, like let's say you're on vacation in Florida and there's an unexpected slip and fall, right? You're brand new to that hospital. A lot of the times, hospitals may not have that information. We don't have a national medical record, right?
Right.
And remember, a hospital's medical information is their proprietary ownership. You have access to it, right? And you can sign permission to have it sent somewhere, but other hospitals may not have connections to the electronic medical record. There may be contractual issues that they're not sharing. um, or let's say that they just don't have anything and you aren't there with your loved one because they took them in an ambulance, so they're kind of showing up and you're 30-40 minutes behind and you
Mm.
can't sign those paperwork, right? So again, it's information. If you can show up the 30-40 minutes later and give a good medical history, say what medications they are on and what their kind of baseline is, that's going to be helpful. But if you don't know the information, at least know where to get it. Like, oh, we go to CVS on Main Street in my town. Call them. Boom. That helps so much. Here's a primary care doctor. Actually, she sees a cardiologist. Here's his number. Be the owner of the information, or at least know where to get it. And that's the first way you can start advocating for your loved one.
That's amazing because I think oftentimes people aren't thinking in terms of that. I feel like there are 5 phases of caregiving. And so, unless you are in that phase where you are that POA, power of attorney, is activated and you are now actually making those decisions, I think a lot of families get kind of caught up in this middle space just before
Mm,
that, where they aren't fully stepped in.
yeah.
But usually it's after they've seen you that, or not usually, just oftentimes after they have been to the hospital, that's when things escalate a little bit. So it sounds like you mentioned in the book a pre-hospitalization checklist. Is
Yeah.
are these the types of things that are on that checklist?
Yeah. Know your medication, know your medical history. I always tell the story about being a third year medical student, and I'm doing my physical and history, and I'm done with the whole thing. And I say to the gentleman, "Oh, can you tell me about your heart operation?" He goes, "What heart operation?" And he's like, "Well, you've had a heart operation." He's like, "I have not." And third year med students don't know a lot of things. They're learning, but I was pretty sure the scar going down from his sternum all the way down was open heart surgery. And I said, "You have this big scar." He's like, "Oh my goodness, you're right. Um, I had something, but I don't remember." Right. And so that's where practicing having your loved one put down their medical history, or you having a copy of it, or knowing what's going on, that's really important. But for caretakers, one of the things that I really drive home is there's the legal framework. And you kind of
Mhm.
alluded to this when you said power of attorney. There are some other legal documents that are important that I think everybody should have a conversation and fill out. One is the MOLST form or the POLST form. MOLST or POLST, depending on your state. This is the mobile orders of life-sustaining treatment or the portable orders of life-sustaining treatment. In my book, I do have a QRS code that you can scan, and it will take you to your state's data, to the national database. You can find your state and download your state's form. What this form says and is what do you, as the patient, want done in the case of a cardiac or respiratory arrest? Right?
Mhm.
So you sit down and you fill it out with your primary care doctor or your primary care provider, and you have it signed. It's in the state of Massachusetts where I'm located. It's a hot pink form, right? You can't miss it. So your primary care doctor scans it into their system and keeps it in their system, or you stick it on the refrigerator or whatever pile of documents that you keep in. So if something happens, someone can easily pull it and say, "This goes with you."
Mhm.
And this can speak for you if you can't speak for yourself or you're not there to speak for your loved one, right? The backside in Massachusetts goes into more complicated things like tube feedings and dialysis and things like that. But the front side and the part that I want everyone to think about is CPR, electric shocks, medications, and intubation. Just what would you want done? What would your loved one want done in that case? And these are medical orders. These are not suggestions. These are medical orders, right?
Mhm.
And so they go with you, and the emergency medicine team can say, "Hey, we have this very clearly signed MOLST form that says that they would not consent to intubation," right? And this, again, we talked about information. This is information. The next piece of legal document that I suggest everyone have is a healthcare proxy or an advance directive,
Mhm.
right? They're not the same thing. They kind of meld into each other. A healthcare proxy is a document in which you designate who should speak for you in case you are not able to speak for yourself in a medical setting. Legally, it is different from a power of attorney, and I'll leave people to have that conversation with their legal advisor, because I know like power of attorney can also have financial implications, and healthcare
Mhm.
proxy is talking about making healthcare decisions, right? And an advance directive takes that one step further. In an advance directive, there's a section that usually says, "Hey, I would like my sister Jane to be my healthcare proxy." But then it says, "And these are my wishes." And a
Mhm.
healthcare proxy then goes through and allows you to say anything you want about your care. I have seen healthcare proxies that are as Spartan as Jane will be the one making my decisions, and that's it. And then I've seen healthcare proxies that are extremely detailed, saying I would consent to intubation for X number of weeks, and I require, a trial of
Mhm.
spontaneous breathing. I would not consent to tube feeds. I would consent to tube feeds, but not a permanent port put in through my skin and into my stomach. I've seen really just kind of fleshed out ones and really sparse ones. But again, what that is your voice. And
Right.
it is giving people information so that they're representing you and they're doing the things that you would want done, if you're not able to speak for yourself. So that's a big part of my pre-hospital checklist is information, own it or know where to get it, and
Mhm.
then be prepared with documents to speak for you in case you can't speak for yourself.
And I think that's so important because so often decisions are having to be made very quickly. And I know in our family, we had a situation where my mother in law, who was living with advanced dementia, was to the point where a blood transfusion was being required to sustain life. And so then it gets into this very gray, confusing place for families about morals and what is our role. And we just, I don't know,
Mhm.
we kind of lost our way. And when you first said
Yeah.
medical orders, what I actually heard was medical borders. And, and I think that, a decision was made very quickly. And ultimately, we were like, oh my gosh, she has the living will, right? Like she had already
Mm.
made those decisions. So it's encouraging caretakers, care partners, care to like have that information so that people can make those decisions quickly for their loved one.
Yeah. Yeah,
So important.
medical decision making, particularly when we talk about speaking for and making decisions for people who require complex care but are not able to clearly state what they would want. There's a whole field of study, right? Medical ethics is people get degrees in this and they have conferences and they write books and they talk to each other across the continents and the country because these are not easy choices.
Right.
These and it comes with not just a fear that you're doing the right thing, right?
Hmm.
But there's things like someone's values culturally and religiously, both parties, the patient and the person making the decisions for them, right? Because that person, though they may be acting as if they're the healthcare proxy, which means I'm doing what that person would want them to do, they still have to sit right with the decisions that they're making for,
Right.
and live with those things, right? There's things like prior experiences with pain, prior experiences with illness, seeing other people going through things. And then the unknown of we don't know what would happen if we didn't do. There's no reset button to say like,
Right.
oh, we'll do the blood transfusion on this version and we won't do the blood transfusion on another version, right? And so, like I said, it's a whole field of study, and it's not easy. Um, if I'm coming to a family for decisions, it's usually because there's no easy one.
Hmm. There's no straight path forward. So we have options and there's different consequences based on different choices and potential outcomes. It gets very hard very quickly, which
Yeah.
actually is a great segue into um, mental health and how are we helping ourselves as we're having to manage a hospital stay with mental health as a caregiver.
So, the biggest thing that I really advocate for caregivers is for them to not do it alone.
Mm.
Oftentimes, caregiving is a lonely experience. You may be at home with someone for many hours, or if you do have hired help, your heart and your mind is still with them, and you're always checking in. And caregivers tend to be people who don't want to burden others. Um, but a hospitalization is an active process. Things move and change really quickly, uh, but it doesn't stop the rest of the world. And so what I say to caregivers is please don't isolate yourself. Ask for help. If somebody's willing to come and sit with mom for a couple hours so you can run errands, take them up on that offer. Take a break and go do those things. Get rest. I know that's easier said than done. When my daughter was in the NICU, I had a really lovely neonatologist who kicked me out and said that you've got to sleep. If you don't sleep, you can't do anything for her, right?
Right.
So try and go home, get rest as best as you can. If that means having a schedule where people come and take shifts, people bring you food, reach out to the primary care doctor so they know what's happening and they can also be a source of support and helping you make decisions. But please don't go it alone because it's not going to end with a hospitalization. It's likely going to get more complicated, right?
Mm.
Caretaking after a hospital stay, like unless you're caretaking for your 22-year-old son who, broke his arm playing baseball, um, caretaking after a hospital is gonna be a lot more. and it's going to take a while for things to even out, for you to find a pattern. So don't burn out on the days that somebody is in the hospital. Take whatever supports you can.
Oh my gosh, I've never thought of it in those terms, and you're absolutely on point. Obviously, that this is an acute situation, crisis, or a situation that we're managing, but then it's going to get more complicated after you leave. So, nourishing yourself or just protecting your energy is going to be really important. I never thought
Yeah.
of it like that.
Post
Yeah.
discharges, right? You may be leaving with new medicines, new appointments, new equipment, if they can go home. If they can't go home and you're talking about a skilled nursing facility, a short-term rehab, are we transitioning to long-term care? Does that mean I have to get case managers involved or legally involved, financially? Like, there are very few times the hospital stay ends with, I'm better. Very few times, you know? Uh, Even for those of us who look forward to going to the hospital to have a baby, you leave and it's more complicated, right?
That's it. Oh my gosh, you are absolutely right. Yes.
So,
I love that you in the book also peel back the curtain to just the system, how the hospital system works. There's so many people that are coming in and out of the room. There's so many moving parts. There's times of day with rounding. I always advise people to do their best, even if it's a 6 a.m. to 9 a.m. window, to try
mhm,
and be in the room with their family members so that they can actually talk to you when you are
yeah,
rounding, because secondhand information, or little notes here and there, or passing information through the nurse can just get confusing and hard. So, just walk us through a little bit more about the hospital system. Like, how does it work? It feels very mysterious and a little scary.
it is. It's all of those. I'm married to a primary care doctor, and he says, like, when patients in the hospital, I don't know what happens. They come out and they don't even know what happened, right?
Right.
It's shrouded in mystery because things move so quickly. There's so many people and so many moving parts that have to be coordinated. So there are a few kind of setups with hospitals, and I go through it in the books of, like, it depends on what type of hospital that you are in, that your experience may change. So there are hospitals that are very, very small, right? So there's such things as a critical access hospital,
Hmm.
and they're really kind of the backbone of rural America, where there are these small hospitals, 25 beds, and they're able to take care of patients, stabilize them, and say, like, okay, if this isn't something we can care for here, we kind of get them moving, right? That's going to be a little bit of kind of a two-tier experience, like feeling like if somebody can stay there, then that's a smaller, more intimate setting. There's not going to be that many people. They can likely stay there because they're not that acutely ill. It's not that complicated.
Hmm.
But if someone has to be transferred out, right, how are you going to coordinate that and follow them to where they need to go, right? And then you have community hospitals where, like, the bulk of care across the country is done. And they kind of have a mix of how they see patients and who staff them. You may have some that have academic ties, and you may have some that don't. So I am working at a place currently that has, like, a mix of academic ties, but I am a private hospitalist. I don't have residents seeing my patients. I see all of my patients myself. When I was at an academic institution as a resident and a chief resident teaching attending, I worked with residents. So my
Hmm.
residents went and saw patients and rounded, and there were so many different touch points. But you're right, the current system that I'm in, I'm it. So when I'm
Hmm.
rounding, it's so beneficial for me to have family members there, because then it's either circling back to try and make phone calls and catch up to people, or, like you said, messages kind of get moved around and not really to who you're looking for. So what I suggest to people is, with a hospital stay, try early in hospitalization. When I say early, I mean, like, try to stick with someone if you can throughout their admission process. And I know I'm saying if you can, because
Hmm.
everyone's situation is very different, right? But try pretty early in the hospitalization to set a communication goal that is clear, that is easily achievable, and that is something that can be passed along to the next team member. So it's like, hi, I'm her daughter, Monique. I am working with my mom. I'm her care partner. I'm her healthcare proxy, whatever it is.
Mm-hmm.
I would really like it if we could touch base after you speak to the cardiologist, right? Can we touch base once a day? Can you give me a call after the CT scans are done and you come up with a plan? Whatever it is. But if you can talk to the care team and make that plan early and make it
Mm-hmm.
achievable, that is really big. And what I mean by achievable and reasonable,
Mm-hmm.
nobody comes into the hospital and makes demands without a history, right? I
Mm,
once had a patient whose daughter wanted to be called every time the patient got medication. Now, if you know the hospital, that is a really unrealistic request.
yeah.
Med pass for a nurse is a really high safety point, right? They have to get the medicine right to the right person. Medicines, right? Some can be mixed with fluids, some can't be mixed with fluids, some can have to go before the other. It's a high safety. They're not making tons of phone calls. They cannot be interrupted. But also the amount of times somebody may require medication and then you have to call someone and tell them that they're getting it. Do they want it? Yes or no? It's that was not really achievable. That was not, but where was that coming from? That was coming from
Right.
prior experience, right? That was coming from feeling out of control, feeling like in the past she had something happen around medications. And this is how she felt she should be able to control the situation, right? So I was able to navigate that by saying, okay, instead of you asking the nurse to call every time she gets a medicine, I will go through the medication list with you on a regular basis. And if
Mm-hmm.
I change a prescription, I will let you know. Right. So that's
Yeah.
how I navigated it. But that was like not achievable, not reasonable, and sets
Right.
people up for now. They didn't call, she's angry, and the care team and her have like a strenuous relationship. So it's really hard because as much as you're doing your best, the people working in hospitals are overstressed, understaffed,
Mm-hmm.
and what they may feel like is their best may not feel like their best to you. You're in a high anxiety and acuity situation. They work in a high anxiety and acuity situation every day. So to them, what feels high anxiety to you is run of the mill. And so it can be a really emotionally charged situation. And that's why
Yes.
I say, like, if you can somehow meet with the team or get the message to the hospitalist with a communication plan that is achievable, reasonable, and do that early, then you kind of set people up for success, including yourself, because now you feel like you are getting the thing that you need. The other thing I say is pick one person, like pick
Mm-hmm.
one person. And I know everybody's children love them and all the cousins want to visit,
Mm-hmm.
but if those messages don't get to the person who is making the healthcare decisions or the person who's going to be catching them when they come home, right? Their care partner, their caregiver, um, that's going to, again, set up a situation where somebody is unhappy, right? So have one person who is a contact person and the person who communicates with the hospitalist or the care team, whoever it may be on the care team. If you feel like there's more people who need to be involved in the conversation and you want, your aunt called and this and that person called and someone, then it's time for a family meeting. That
Mm-hmm.
should make you say to yourself, okay, there's way too many people who are looking for input or who I need to get information to support me to make decisions. Let's get everybody in a room so that we are all hearing this information at once. We're
Right.
all able to ask our questions, and then we can make whatever decisions need to be made, right? But it's not really reasonable to expect that your hospitalist is going to be able to call two and three different people every day
Right.
because they have like sometimes upwards of 20 something patients that they're caring for, depending on the institution.
Mm-hmm.
And so to make that many phone calls, they should be making phone calls for care. They need to be talking to their colleagues to advance your loved one's care and making plans and, filling out the appropriate paperwork to get them to the next step, to get them the thing that they need. So kind of trying to streamline that communication also sets you up to be like, okay, I'm getting what I'm looking for and I feel empowered. I think you and I give some kind of similar advice.
Mhm.
I tell people that, like, if you feel like that you have to be at the bedside to get what you need, then be at the bedside, right? I once had a gentleman come to one of my talks and he was very angry and said, last time my mother was hospitalized, it didn't go anything like what you said. And if I didn't show up from 9 a.m. and stay to 3 p.m., I would never have spoken to the doctors and the social worker and the physical therapist and the dietitian and the this and the that.
Mhm.
And I said to him, well, if that's what you need to do, then do that. I don't have an easy answer for
That's a
that.
lot of expectation management and
Yeah, I don't have
time.
an easy answer for that because a lot of those people will never call a loved one.
Right,
A dietitian is very unlikely to call a decision maker unless there's something kind of outlying and they need a little bit more information. The physical therapist is not going to call every time they get your loved one up and walk down the hallway.
right,
And so if those are the people that you feel like you need touch points from, and the only way you feel you get that is by being there for those hours, then do the thing you need to do, right?
mhm,
But also, if you can present yourself, and it doesn't have to be every day, right? Because sometimes during a hospital stay, things don't change. After you get like a good care plan, you've gotten all your scans, the antibiotics and everything are going. You may have 1 or 2 days that are just kind of like, okay, let's continue with this care plan. Things
mhm,
things are not as acute anymore, right? But if you can present yourself and meet the care team, you're going to be able to give them so much information. And it's not
yeah,
just about you getting information, it's about you giving them information, like around mental status, around somebody's capabilities in the home, around their pain. A lot of our older folks don't say when they have pain, right?
right.
Right. So you're going to be able to give as much information as you're going to be getting. And that again does what? Sets up a safe plan. And that's the
Mhm.
number one thing that we're advocating for is safety.
So is baseline still a word that you use in the hospital? That's a word that I have coached a lot of people to utilize, which it's like this is not their baseline. Like this is not where they were a few days ago because you, as you pointed out, are seeing just like a snapshot in time of someone. So it's hard to know where they were at and what they were capable of. Is that still a buzzword for you?
Baseline's a great word.
Okay. And then something else that is coming to my mind is those first couple of days when you are trying to understand what the situation is, what the status is of your patient, and determine what your next steps are. I agree, those are super critical days. And then it sounds like there's a couple of days where maybe your loved one has stabilized a little bit, like we're all taking a deep breath. You are watching and monitoring to see if the interventions are working or if anything needs to be changed. And then in my experience, discharge happens fast and furious. Like once you have decided, you know what, this is working, they don't need to be here anymore, they're stable. We want to get them to a different environment, whether that be home, to your point, skilled rehab, nursing home, assisted living. Anyway, it just happens so fast. Can you
Yeah.
share a little bit about what is like what are y'all talking about that we don't know that is making that decision quickly? Because as soon as I hear that someone is doing better and stable, I'm like, okay, I'm telling you, they're talking about discharge.
Mhm. So you're right. If somebody is improved and they're no longer requiring a hospital level of care, meaning that the thing that I'm doing for them doesn't need to be done in the hospital anymore, right? They're getting antibiotics that are pills. You can swallow pills at home, at a nursing
Mhm.
facility, whatever. You're no longer having that wound looked at every day because the surgeon is happy with it and says, like, leave it on there for a week, don't touch it, right?
Mhm.
So If it's not hospital level of care, then the conversation starts going, okay, where can the patient be cared for next, right? Um, those days that someone is stabilizing and we're watching the intervention and making sure things are going well, those should be just as active logistically as the prior days were medically, right?
Okay.
Those are the days that I say to people, okay, I want you to get on the phone and start making phone calls to get appointments, right? Because those appointments, if you try to make an appointment after you leave, it's too late. Those are the days you should be setting yourself up to realize, yes, you're right, you're going to be leaving the hospital soon. The case management team, the social worker team, the caseworker team, whatever they call it at that hospital, is going to be the team that is responsible for making sure they're coordinating a safe discharge plan,
Hmm.
meaning you have access to the medicines you need, you have access to the specialists that you need and the follow-up that you need, and you're going home in a way that's safe and secure, right? So if they're saying like, oh, worked with physical therapy and you just aren't safe to go home, now we need to start thinking about a rehab, then you have to say, okay, work with the case manager because it's going to be, what does your insurance contract with? What are you comfortable with from prior experiences and what you've heard? Logistically, you don't want your loved one like ultra far away.
Hmm.
What's something we can access and finding a good match for you, right? And so those kind of medical stabilized days should be logistically very busy. And this is where I said, like in the beginning, a hospitalization is active. It's an active process. And as a
Hmm.
caregiver, you're like, you may think like, okay, they're just getting her antibiotics. She's looking better. I can breathe. No. Now you have to say like, oh, but she needs a walker. How do we get a walker? Okay. Do we have the prescription for the walker? Like it is a lot of moving parts.
Yeah.
And so really you should be asking those questions on those days. Like, oh, mom's kind of stable. We're not changing the medical plan. What is the discharge plan? What are we thinking we're doing? I like to talk about discharge on the day you're admitted. And I
Hmm.
know sometimes family members kind of bristle at that. It's not because I want you gone. When I ask, where do you live? And do you think you'll be able to return there? It's because if the answer is like, look, he broke his hip, he has 18 stairs to get up. Okay. No, he can't go home. I got to be on alert to talk to the case managers early about finding a place for him to go next, right?
Hmm.
Or it's the exact opposite sometimes where people say, like, look, we have 24-hour care at home. We've got nurses who come. My brother is a heart surgeon who's won 10,000 awards and can do everything. Send us home. We can do whatever.
Yeah.
Great. But now I have to make sure that you can get those things delivered to your home, right? Am I working with the pharmacy to deliver the antibiotics to the home? So it is a lot of moving parts wherever you're going next. And so you totally are right. If you're hearing someone say, like, oh, things are kind of stabilized and they feel like they can breathe, you're right to be like, okay, they're thinking about discharge. You got to be thinking about discharge and you got to start asking these questions as well. The case manager is the key. That is the key team that you've got to get plugged in with.
Hmm. That totally lands with me. And I think a lot of times what I'm encouraging people to do is either stay in the hospital for another night to buy us a little bit more time to prepare for what's next, or we really are hoping that someone will go to a rehab facility versus going home, because a lot of times it's another elderly person, or we just don't have those home care supports in place. We don't have the amazing son who's a cardiac surgeon with 10,000 awards, right? We have our brother who flies in, says everything is fine, and then boogies back out.
Yeah.
So just like trying to buy time, I guess we had touched on this, like how do we find this like happy medium? Because obviously we don't want people to stay in the hospital for extended
Yeah.
periods of time. It's expensive. There's, other things are happening in the hospital. There's potential for infection, things like that, I believe. Correct me if I'm wrong. And then, so like, I'm trying to just figure out what's our happy medium with buying time and getting set up for success.
Touching base with the case management team to have an open and honest conversation as soon as you can in a hospital stay.
Okay.
If you know that it's just two elderly people in the home, my going on 15 years of this, I can almost guarantee you they're going to be like, we can do it.
Yeah.
We're fine,
Yeah.
right?
We're doing
They
just
want to be
fine.
home. We'll leave me and my wife alone. We'll figure it out, right? But you're their daughter, you're their neighbor, you're their loved one, and you know that they need a little bit more than that. Giving the case management team a heads up early in the hospital stay and saying, like, look, after discharge, we need to talk about rehab. We we would prefer a
Mm-hmm.
discharge to a rehab facility. That will allow them to get what they need. The case management team will push for a physical therapy evaluation, right? Because they have to meet a certain level of physical therapy need for active rehab. They can help find skilled nursing needs, right? There
Mm-hmm.
are lots of creative ways that we can find a need for somebody, right? Um, and they can work with your insurer to make sure you haven't run out of rehab days, because that's the
Mm-hmm.
big one. That, if someone's been in and out of rehab, they may not have those days that they qualify for anymore, or they can tag it on to another rehab stay. So there's a bunch of logistical things that they can help do. But the sooner that they know the real needs, and I really want to press for that open, honest conversation,
Mm-hmm.
because you and I, we want the same thing. We want success after discharge for people,
Right.
whatever that means, right? And I have seen people fail every discharge plan you can think of, including end of life,
Mm.
right? When people think like, how can you fail hospice? I have seen people fail hospice at home because they didn't have the thing they needed.
Ah.
They weren't capable of doing that thing,
Mm-hmm.
right? And that's where open, honest conversations is saying, this is what we can do. This is our need. Help us find a way, because you want someone to thrive after, wherever they may be. And it may not always be permanent. Like, a rehab doesn't mean that they're going straight to long-term care, which for a lot of elderly people is their fear, right?
Mm-hmm.
That, but try to allay those fears and say, like, Dad, but if you go home and fall again, you're really gonna have to talk about long-term care. But if you go to this place and we can get you stronger while I figure out how to keep you safer at home,
Mm-hmm.
right?
Yeah.
None of this stops with the team in the facility.
Right.
All of this hinges on what continues afterwards, right? And so, yes, they may go to rehab for a week or two, but if you've got to like move a bed from upstairs to downstairs, like, you have the time to do that.
Right.
You it all hinges on making a safe plan for wherever you consider their final destination to be. And if home is it, even after living rehab, it's still going to be more complicated,
Mm-hmm. You're absolutely
right?
right.
Even
Yes.
after that.
One of the things that I think is so funny is I don't know why it's always 4 o'clock on a Friday when the decision is finally made to go to the emergency department. Like that, it's like we've had all week, we've had little suspicions here and there.
Yeah.
We're like sitting in their living room at 2 o'clock, shaking our heads. And then by 4 o'clock, I mean, I've been a caregiver for four different family members, right? And it's
Yeah.
so consistent that it's like
Yeah.
late afternoon on Friday. I guess we need to go to the hospital. How would
I
you?
think everyone's just kind of plugged into that work week. I don't know.
I guess so too. And in my experience, just once we get there, like Saturday and Sunday are a little bit slower in the hospitals. Is that accurate? Like we don't have all of those specialists necessarily. Like sometimes people are available, but not always.
So academic institutions will tend to run a little bit more 7 days a week. And that's just because, again, they have residents and ultra specialized things that kind of require people to be around or are available. But it's not just the physician specialists who may not be around at the community hospitals or other hospitals, I should say, on the weekends. You may not have the specialized techs to do certain radiology testing or to support the physician to do certain procedures like cath
Mm.
lab procedures, right? So nobody does anything in isolation. And the amount of support that it takes to do procedures, radiology testing, biopsies, um, pathology staining, labs, all of those things require a lot of people. And those people, like most of the world, tend to work, 5 days a week.
Mhm.
In addition to the fact that not everything happens in every hospital or hospitals all the
Mm.
time. So, one big one that I get is mammograms. People often ask, Mom is here, can we just get her mammograms? Mammograms are very notoriously not done in hospitals.
Mm.
And we will do breast MRIs in hospitals, but those are very specialized tests looking for things that we are following up on cancers and stuff like that, right? And so the institution may not do that test, number one. The tech or the radiologist or the whoever to carry out the test may not be available.
Mhm.
And so the procedure may not be possible, right? And it's the same thing with the lab. Not every lab runs every test, right? So most hospitals or their labs are able to run a whole bunch of tests, most things that you ever need. But anything that's ultra specialized has to be sent out. And the mail doesn't run 7 days a week.
Right.
Courier services don't run 7 days a week. But then, even if you can get it to the specialized lab, that lab may not be running that machine 7 days a week. It all comes down to the supports that the care team needs to be able to care for patients. Oh, and don't forget, your insurer does not work 7 days a week. They take every holiday and they turn off their phones at 3:30 on a Friday, not at 4.
Oh my God.
And so and so case management can't get in touch with them to say, hey, we need a place for somebody to go. We have this thing. Can we get home antibiotics and things like that?
Right.
So there's a ton of people who work in the system who don't keep surgeon hours.
This is such a good reminder just of expectation management, how we are a full ecosystem. There's this whole continuum of care that is happening to help take care of human beings. And I am so grateful to you and the team that you work with and your willingness to continue to show up every day. I know that it can sometimes be a thankless job because we are in a high emotional state trying to quickly problem solve for our family
Yeah.
member. And so I'm just want to express to you gratitude, A, for being here with me today, because this was time out of your busy schedule, but then also just keep showing up and just to encourage you that we do need you desperately.
No, I think it goes both ways. Caring for somebody at home, and not even just at home, but navigating people through our healthcare system is extremely difficult. And caretakers are just a whole other set of angels. And so we're very, very thankful for active family members and caretakers who help us with getting their loved one what they need. And so thank you again. This is a really great community, and thank you for helping me get my message out there. I really want people to have a little bit of information and preparation on their side.
I love it. Well, we're all in this together, and your book, Prescription for Admission, it's got
Prescription
a
for admission.
prescription for admission, so valuable. And I love one of the little snippets was, I want you to read this book and come away with your game plan for each day in the hospital, your list of needs and questions, and your mechanisms for communication with the care team and advocating for yourself. So thank you so much.
Thank you. Yeah, thank you again. It's available on Amazon, barnesandnobles.com, anywhere you buy books. And I want everyone to get a copy of it so that we can feel a little less frazzled when the next time we have to get into the hospital. So thank you.
I love that. Keep it moving. What I know for sure is that things are going fine until they're not. Everyone wants to stay in their home for as long as possible. And then there's a fall or a hospital stay or clear signs of dementia or a diagnosis, and remaining at home becomes questionable or potentially impossible. It is super important that you are informed about what assisted living and nursing home care can offer and understand how to choose the one that will best fit the needs of your family. I know from personal and professional experience what objections are going to come up and how to navigate those conversations. You love your family member and you are doing a great job. It just feels like the situation is fragile. You're waiting for the other shoe to drop and you don't know what you don't know. Illuminating Senior Living answers all of your questions and walks you through step by step each common objection and frequently asked question. This course will save you so much time and heartache. Imagine knowing exactly when it's time to move and ensuring the care and safety of your family member. Imagine knowing what specifically to be looking for in a care community and how to have the conversations about moving. Illuminating Senior Living gives you the roadmap so you're prepared. Click the link in the show notes, Illuminating Senior Living, to secure your video course today.